Hello, everyone. Welcome to this webinar on adhesive dentistry, how to do it and when to glue it. My name is Alex Fasserman, and thank you so much to Viva Learning for giving me the opportunity to share some work and how I restore teeth in my practice. So without further ado, what and how do we do it when we need to do something? And this is all has to do with adhesive dentistry and the thought process that we take whenever we see a tooth that needs to be restored. So hopefully you will learn something. And again, I'll provide my email at the end of the lecture. And if you have any questions, please feel free to email me. So the objectives of today's, I want everyone to understand the difference and review the difference between adhesive dentistry and cohesive dentistry. What does that mean? We also want to review the prep design for adhesive and cohesive dentistry, update on current bonding principles and techniques and how I do it in my practice, and review today's dental materials and protocols, cements, bonding agents. Hopefully there'll be a lot of pearls that you could take with you tomorrow when it comes to, again, adhesive dentistry. A little bit about myself. I'm a Spear trained, COIS trained dentist. I did my residency at Wyckoff Heights Medical Center. I am sponsored by Bisco, not because of any reason, but I was using a lot of their products and I reached out to Rolando. I met him on one of the meetings and he said, I love your work. Why don't we do something together? So I am sponsored by Bisco. I do work with Sprint Ray. I am a director of our Seattle Study Club here in New York City. So yeah, intellectual growth should commence at birth and cease only at death. So I'm always learning. I'm always studying on latest bonding techniques, implantology, cosmetics, and restorative dentistry. This is my practice in Manhattan on the Upper East Side of New York City. That's me with the glasses. I know you can't see me, but that's me. I treat everyone from Fortune 500 people to the doormen that open their buildings. So all across the board. Big inspiration to Frank Spear, John Coyce, Rolando Nunez, who's in Bisco. You'll see some of Nate Lawson's work here. He's great. He has a dental channel called Dental Tube. And of course, Paul Homily on how to present cases and talk to people. So big thank you to everyone here, especially John, who for a lot of the stuff you'll see here is from John's lectures, and big thank you to him. Yeah, so imagine you have a hygiene check, patient's in the chair, and your dental hygienist points out that there's secondary decay, that there's a distal fracture on this tooth. The tooth is sensitive to hot and cold sensitivity. Again, reversible pulpitis versus irreversible pulpitis is reversible pulpitis is when it's sharp and quick, where irreversible is lingering pain. So in my practice, I have a little cold pellet in hygiene and in my room. Anytime that someone says cold sensitive to a tooth, I will always test it. I'll take my endo ice, I'll put it on the tooth, I'll test it. If it's reversible pulpitis where it's sharp and quick, you could restore it without endodontic therapy. If it's irreversible pulpitis, they probably at that point they need endotherapy. So pearl number one, always test the tooth. So when you're looking at this tooth, let's say it's a reversible pulpitis, you know that it could be restored without endodontic therapy. You kind of go through your options in your head. I could replace the amalgam. I could put a big old MODBL XYZ composite. I could do glass ionomer, or I could put IRM, and then an indirect restoration would be inlay. I don't do inlays. For me, in my hands, it's really hard to cement. It's really hard to then dig them out when you have to change them out. So for me, it's either going to be direct restoration, which is composite, or it's going to be an onlay 3/4 crown or a full coverage crown. So an inlay is off the table. I don't do inlays in my practice. So it's either going to be, if it's something like an inlay, it's going to be a composite restoration. It's going to be direct. And in those thinking processes, you always remember that you want to leave things better than you found them, especially people. So whenever I'm restoring a tooth, I want to restore it for 20 years. I want to do the best job I possibly can. And I don't want them to ever have to restore this in 5 years or in 10 years. You know, I'm going for 25 years. And if I have to prep a little bit more to buy them extra 10 years, I'm going to prep just a little bit more. So if I have to shoe a cusp, but that's going to increase the longevity of that restoration by 10 years, I'm going to do that. I'm going to shoe that cusp, you know? So direct restoration is going to be when I have these big cusps and it's and very little reduction, and indirect restoration is when I'm going to be shoeing the cusps. And again, our job is to do no harm, to leave the tooth in better condition than you found it, and to be minimally invasive whenever we can to preserve as much as biologic tooth structure as you can, but also increase the longevity. You don't want remakes. You don't want to have patients in your waiting room 2 years after you cemented a restoration asking why you can't use better glue. Why did this come off? Why did this break? What kind of risk factors? And we all have remakes and we all have failures, but how do we minimize failures? And this is in this lecture, I'm going to take you through some of these steps so you could minimize your failures. Okay. So if I'm going to be doing my direct, if you look at the cusps on the buccal and the lingual, there's plenty of tooth structure. So all I'm going to do is remove the restoration and put a composite. I'm not doing an inlay here. This is going to be a direct composite restoration under a rubber dam adhesive. This is not a direct lecture, but I will cover it with bis cover to seal in the composite, and those are my steps. This is more of an indirect lecture, so I'm going to take you through my indirect steps. To me, this is always an indirect restoration. The cusps are coming off here. I'm going to shoe the cusps. I'm going to remove the restoration. Whether I'm going to put something on the inside or not, I will take you through my thought process. So in a lot of practices, this would be a core buildup on the inside and a 360-degree crown. In my practice, there's going to be something more conservative. So I'll take you through the thought process here. And again, whether you go adhesive and cohesive, this is the key. This is the big key here. It's whether you have presence of enamel or not. If you have enamel, you can go adhesive. You can bond to the enamel, and it's a very predictable bond. If you don't have enamel, if there's no enamel rods and it's all dentin, and you prepped through the enamel and it's just dentin, you have to go cohesive. This is where you have to grab the restoration. Why? Because if you're going to bond to dentin, it's not a very predictable bond. I don't care if you're dental sealing, if you're doing XYZ, it's not a very predictable bond. So you have to grab the tooth so that restoration lasts 10, 15, 20 years at least. So I will take you through what is adhesion. Adhesion is the state in which two surfaces are held together by interfascial forces, which may consist of valence forces or interlock. But think of adhesion as bonding, as gluing something really predictably. When we're bonding to enamel, it's not only interlocking forces, but it's also covalent bonds, right? So think of adhesion bonding. You're predictably bonding to the restoration, bonding agent, resin cement, and that restoration is staying put. Why? In 1955, Michael Bonacore realized that when we apply inorganic acid or phosphoric acid to the surface of the enamel, these pores start to open up. And whenever we're etching enamel, bonding agent then goes into these pores or microporosities, and not only do you have a covalent bond, but you also have an interlocking bond, which is adhesion. So bonding to enamel is incredibly predictable. We do this with veneers. Whenever you're looking at veneers, you want to keep it all enamel. You do that with posterior teeth. You could go onlay if you have onlay, or a 3/4 crown if you have enamel. But if it's all dentin, it's not going to be a very predictable bond. Why? But dentin, if you look at it under a microscope, is very porous. And not only is it porous, it's wet. Also, inside dentin are these metalloproteases that over time, and this is from a great study from Compendium in 2011, they showed that over a year down the road, the bond to dentin diminishes by almost 40%. And it doesn't matter if you particle abrade, dental seal, etc. These metalloproteases will degrade the bond. Why? Dentin is 90% organic, and it's made out of collagen. So it's like bonding to a wet sponge. Doesn't matter if you dry it, if you desiccate it. If you don't have enamel, bonding to dentin is very unpredictable. And the patient, especially if you're doing a veneer or if you're doing a restoration where there's a lot of occlusion or interferences whenever they're chewing, that restoration is going to pop off. And then they're going to ask, why did you not use really strong cement? So dentin, not predictable. Enamel, very predictable. And that's how you're going to decide whether you go adhesive or cohesive. So whenever I'm looking at my restoration, as soon as I remove that enamel, you will look here. This is all enamel. Beautiful enamel rods. You could particle abrade it, you could etch it, you could bond it. Now, I don't care if I can get a bond to dentin, it'd be great, but I'm not relying on that bond. I am relying on the bond to enamel. Enamel is the key here. And it doesn't matter what you're bonding to it. You could bond zirconia, you could bond lithium disilicate, you could bond composite. As long as you have enamel, it's a predictable bond. So for adhesive dentistry, you need occlusal clearance for lithium disilicate of 1.5. Certain, like Ivoclar, could say that it's whenever I'm prepping for an Emax restoration, it's 1.5. Zirconia, it's going to be 1. Axial reduction is going to be aesthetic driven. So I could bevel to blend in the color so you don't see the margin, especially on the premolar. Maybe I'll move the porcelain all the way to the gum so I could blend the color. But on the axial, on the buccal, it's only for color, right? If I have that 360 degree of enamel right here that you're looking at, or right there, that's where I'm bonding to. And the challenge is when you are bonding to enamel, you have to do it under a rubber dam. You have to make sure that there's no moisture present. You have to make sure that it's dry, it's particle abraded. So for me, whenever I'm doing adhesive dentistry, when I'm gluing it, it's underneath a rubber dam. Cohesive dentistry, so let's say you prepped all of it away and now you don't have any enamel, you got to go to cohesive dentistry. And cohesive dentistry is when you're primarily in dentin. It's less conservative because you have to destroy the cusps. This is your standard dental school prep, right? This is going 360 degrees around or bringing some of that prep design to the buccal or to the lingual because you're mechanically grabbing the tooth, right? And anytime you're over prepping the tooth, the pulp will get damaged. So anytime that I have a severe prep where I'm prepping 360 degrees, I will always tell the patient there's about 5 to 10% chance that this tooth may need a root canal. Why? Because I'd rather get ahead of it and tell the patient that there's a chance that this tooth may need endo than them blaming me that I did something incorrect. And so I always get ahead of it. Whenever I'm prepping too much 360 degree prep or I'm being a little bit aggressive with my prep, I always tell them that there's a chance for endo. But it's easier to cement, right? You may not need a rubber dam as long as everything, because you're not relying on adhesion, you're relying on resistance or retention, where this restoration is not going to get pulled off, right? And here are the principles or the prep design. So whenever you're prepping, and this may be a review for some of you, but it's very important to remember what's going to make this restoration last for a really long time. You need the 6 degrees of taper. Anything under 6 degrees, it's going to be really hard to get that restoration on. Anything over, now your retention is starting to decrease, and now you really have to rely on the bond. But remember, bond to dentin is not predictable. So whenever you have an over-prepped restoration, you got to get ahead of it and tell the patient that perhaps the tooth structure is not enough, and you want to get ahead. It's easier to tell the patient that the restoration may fail down the road because X, Y, and Z than to explain yourself when they're sitting in the waiting room with that Ziploc bag, with a crown inside. So you kind of have to know, is it 6 degrees? Do I have enough retention? Do I have enough tooth structure? You need about 4 millimeters of prep height. So whether it's both core and tooth or just tooth, you need 4 millimeters. Anything under that, the restoration's coming off. Anything above that, 4 millimeters, you may now not have occlusal reduction, right? There's not enough of restoration. So at least 4 millimeters of prep height. When you're looking at the tooth, if there's going to be a core, 2 millimeters, at least 2 millimeters have to be healthy tooth structure. Anything below that, even if it's the biggest post in the world, eventually that post is going to give, right? Eventually it's either going to fracture the root or the post and core are going to come off with a crown in it. And you got to explain yourself, why did it come off? So 2 millimeters of tooth structure, 6 degrees of taper, and then at least 2 and 4 millimeters of ferrule, right? And again, occlusal reduction is going to depend on which material you're cementing on. For me, 1.5 lithium disilicate, 1 millimeter zirconium. And in my practice, those are the two main things. It's about 80% lithium disilicate, 20% zirconia crowns. So I'm going to take you quickly through how I prep the tooth. This is a very similar tooth. Patient comes in, let's say that they're cold sensitivity, reversible pulpitis, secondary decay, mesial fracture on the tooth. You could restoration, not enough tooth structure on buccal and lingual to do a direct restoration. To me, this is an indirect restoration. What I would typically do is first take a flattened burr after I numb the patient, and I make sure that it's reversible pulpitis. I remove the old composite, remove the restorative material, just remove it all, just like what you see here. Then what I do, and a side note, I really like these micropy burrs. They're disposable. It's easy. They're always sharp. I'm not sponsored by micropy, but I use them because for me, disposable burrs are great. The assistant sets them up, and when we're done, they just get chucked. I don't have to worry about sterilizing them. I don't have to worry about overheating the tooth, etc. So that's what I use in my practice. Then what I do is I have particle abrasion unit chair side. I use a Prep Star. I used to use these micro etchers. The micro etchers would cause a mess, and you can't really control the pressure in them. With a Prep Star, I know exactly what pressure I'm using. It's 1 bar of pressure, and I use 27 micron aluminum oxide. I particle abrade the dentin floor. Why? It decreases sensitivity and increases retention of my liner. Then I rinse and dry it. Then what I'll do is I'll build up the tooth. I used to use Unisem because it's, when you particle abrade it, Unisem has MDP in it, so it's self-adhesive. Now what I do is I use TheraBase. It's more basic. It releases calcium and phosphate right into the dentin. So if I'm really deep to the pulpal floor, but I'm trying to avoid endodontic therapy, TheraBase is my go-to. I use primarily, you particle abrade the floor, put TheraBase, cure it, and now you can prep right through it, almost like a core buildup. And for a lot of my restorations, if it's not thick and I'm not relying on the core buildup to retain my crown, right, then I'm going to use TheraBase as a simple liner. That's my go-to. And then I prep right through TheraBase. I do my occlusion reduction guides, 1.5 from lithium disilicate, one for zirconia, and then I just kind of flatten it, right? I'll take a football burr or I'll take a flat, and I'll just flatten the restoration. I really like these KSO burrs. They're non-tapered, very easy to flatten the restoration. And then what I'll do is I'll take a really fine burr, I'll run it at 10,000 RPM, and I'll bevel in order to increase how much enamel I have, increase enamel rods, the surface area of the bond, and also to blend for color, because you don't want to have like a sharp line. It's really nice when when lithium disilicate blends into the tooth. And this enamel is where I'm getting all that adhesion from. You're getting it from the top, but you're getting it from the side. And then what I do is I love these flex tabs from Kerr. They come in 1 millimeter, 1.5 or 2. I have the patient bite down, and as long as I could drag it without any resistance, I know I'm exactly at 1.5. You can also, after you scan, you could see how much reduction you have if you're under prepped, but then you got to re-prep and rescan. So for me, these little pull tabs, they're cheap. They're like $1 each. I guess you could sterilize them. I don't. We just chuck them and then we get a new one. And then I smooth out the restoration with these soft legs discs. This is my favorite burr. It's by Diatech. It's great for breaking contacts. It's great for polishing, for getting into those little tiny nooks and crannies. These are terrific burrs. I also use them for IPR whenever I need 0.3 of a millimeter cut. I use these burrs. They're fantastic, from a company called Diatech. Then I'll take my scan, and from studies, any scanner works. It's for a single unit. Medit is a great scanner. I use a 9-tero because we do some Invisalign. Carestream has a good scanner. Trios, all for single units, for multiple units. They're all work, but it all depends on what your ceramist does with the scan. How do they translate it into the restoration? So if your ceramist has a lot of experience doing it digitally, do it digitally. Multiple units, when I'm doing a full mouth rehabilitation, I will still do my, I will still use PVS or Improgum. For aesthetic cases, I will still use PVS or Improgum. Recently, my ceramist, him and I have been doing some aesthetic cases with a scan. The fit is great, but I've had some margin issues. So I still like my PVS or Improgum. Aquasil is a terrific product. You could get Imprint by 3M. My go-to now, what I use is the stuff from Impressive. I think it's less expensive. It's more, it's clearer margins. They have a light body and a heavy body. That's my go-to, is Impressive by Cosmodont. Then I'll make my temp before I prep the tooth. We'll take a copy of the tooth. I'll do that with either Alginate or alginate substitute, and then it just sits on the shelf. So in case they break a temp or if they lose a temp, I have a copy of their tooth. They pop into my office, and while the restoration is being made by my ceramist, I can make them another temp. Luxatemp, Integrity, all of these, they're very, very similar. Honestly, at the end of the day, it comes down to price and how much you could buy in bulk and how much you're using them. They come in different shades. We use a lot for aesthetics. I now 3D print my temporary crowns for aesthetics. So when I used to do this, I used to use Integrity. They're all great. They all work. And then this is whenever you're just using adhesive dentistry and there's not much retention, the temporary cement of choice that I have is this Telio CS Link. It's by Ivoclar. It's a resin temporary cement. It's awesome. I sometimes have challenges taking off these on-length 3/4 crowns. If they're very sensitive, I will still use Tempond with eugenol to take care of the sensitivity. And then what you do is, I know that there's a lot of talk that eugenol interferes with bonding. So for me, I just particle abrade all the eugenol and I particle abrade all of the Tempon off, and it hasn't been an issue. And you can also spot bond and spot etch. You can spot the enamel, and then you could put the restoration on, the temporary. So here is a case that I'll take you through. Patient comes in, there's a mesial-distal fracture. I know that they're clenching their teeth. They're especially in that second molar. We recalibrated their bite so that way to get them off of that second molar whenever they go into CR. And once I recalibrated the bite, I removed the restoration, I removed the mesial crack, I put my TheraBase as a liner, and you could see I prepped right through the TheraBase. I prepped a little bit more on the buccal. I made a little bevel on the lingual. It's a very conservative prep. Only the occlusal was prepped through. I didn't even break contacts. Particle abrade everything. Here's my temporary from, I believe this was Luxatemp at the time. Here's my script. Please fabricate pressed lithium disilicate crown onto the. I was convinced that once I recalibrated, I shouldn't have an issue with a bite. Light occlusion. Second molars will either get no occlusion at all or very, very light occlusion, just enough for the shim stock to pass through, but it's very light. Please return etched. And again, speak to your ceramist. How are they etching your lithium disilicate? What are they using to etch it? Are they etching it for 20 seconds? Is it 9.5% hydrofluoric acid, which is my suggestion? And what shade? Have that discussion with your ceramist. What are they doing? Are you milling in-house? What are you doing to etch your restorations? Because etching lithium disilicate is incredibly important. Zirconia, my script, if that tooth was a zirconia crown, same thing, please fabricate zirconia restoration, tooth number whatever, light occlusion, tight contacts. And I always ask my ceramist to give me tighter contacts than necessary, because it's much easier for me to adjust a contact and remove it versus adding, because that's an extra appointment. I have to send it back to my ceramist. And always talk to your ceramist. Where are they getting their zirconia from? Is it 3Y? Is it 4Y? What batch is it coming from? Is it coming from India? Is it coming from China? Is it coming from US? The zirconia comes in a puck and then they mill it. It's really important that you know where they're getting their zirconia from, because not all zirconia is the same. Speaking of what how are we suppressed lithium disilicate is typical. Again, 80% of my restorations are going to be pressed. Why? Because pressed lithium disilicate, what they do is when I take a scan or an impression, my ceramist will wax the die. So any little imperfections in the margin, any little imperfections in the prep gets covered up by the wax. The wax makes up the difference, and the margin seal is going to be the best with a pressed ceramic. Pressed Emax. The pressed restoration will then get invested, and then it gets stained, glazed, baked in one of these ovens, divested, and then stained and glazed, polished. For me, pressed lithium disilicate out of milled is my choice of restoration. And if you're going to be doing milled, remember that whenever zirconia or lithium disilicate is milled, there's going to be a little discrepancy between the milling tool and what your prep is. So you almost have to prep to know that the milling tool can't have sharp angles, it won't be able to mill those little imperfections in the margin. I mean, they're getting a lot better, but still CAD-CAM, to me, I would rather have pressed in my mouth than a CAD-CAM lithium disilicate. Zirconia, we don't have a choice. It has to be milled right out of these pucks that I talked about, but it's very hard to mill those little tiny imperfections. I find that my prep has to be perfect. My ceramist has to read the margin perfect whenever I'm doing a zirconia restoration. And pressed versus milled has a higher flexural strength, and it's slightly tougher because the crystals in a pressed are a little bit more dense. So the restoration is going to be a little bit more resistance to fracture and fatigue. And you could look at this table. I'll email it to you. The strongest restoration by far is going to be your zirconia. Here's another pearl. Remember, never glaze your zirconia, always polish. Where we're getting abfraction on the opposing tooth is if the zirconia restoration has glaze on it and not only polished. So whenever I'm telling my ceramists, they know you never glaze my restorations, you only polish them. And zirconia restorations for bruxers, for clenchers, for patients that, let's say they broke their previous crown. What's to say they're not going to break your lithium disilicate crown? In those restorations, I'm going to go to zirconia. So those are the 20% of my restorations whenever I need strength. Let's say the patient doesn't want to go through an occlusal equilibration or occlusal adjustment. I'll explain to them that what happened was it wasn't that the crown failed due to biology, it failed due to mechanics. So the mechanics has to change. So in that restoration, I'm going to go with zirconia. But these are the numbers for your pressed versus milled versus zirconia. Zirconia is the strongest as long as you don't glaze it. So here's your thinking process. You see that restoration from Monday morning. They're in your chair. You're prepping it. You're going to go, am I bonding it or am I just going to lute it? Am I going to just cement it on? Do I have enough enamel? Do I not have enough enamel? When do you etch the crown and when do you particle abrade it? If it's a lithium disilicate, do not particle abrade that crown. You're going to create micro cracks in the inside and the restoration is going to break. You only want to etch lithium disilicate by particle abrade zirconia. So those are your thinking processes. When do you use silane? When do you use MDP? You want to silane with lithium disilicate. You want to use MDP with zirconia. And if it was adhesive, am I going to use a rubber dam? Am I going to use a dry shield? Am I going to use one of these retractors that suction and have a light like an isovac or an isolite? And what cement do I use? Am I bonding the restoration by using bonding agent, or am I just going to sit it over the top? So these are kind of the roadmap that you have whenever you're deciding how to prep it, how to design the restoration, how do I take a scan of it? And I'll take you through these processes a little bit more and hopefully give you a little bit more tools. So do we bond the restoration or do we lute it? If it's adhesive and you have plenty of enamel, you don't have a choice. You have to use bonding agent and you have to use phosphoric etch to bond to enamel. It's the most conservative restoration, but it's the hardest to cement. You need to use rubber dam and you have to make sure that there's no moisture contamination. If it's cohesive and it's that old school dental school prep, 6 degrees of taper, 4 millimeters of ferrule, 2 millimeters of tooth structure, you can go cohesive. You can bond, sure, and you could put it over the top, or you could just lute, right? You can use any cement, put it over the top, because now you're not relying on the bond, you're relying on the retention. And let's say you have that cohesive restoration where you don't have proper walls, where you don't have the 6 degrees of taper, you don't have a lot of room to grab the tooth. This is where you bond and pray. It's not ideal. You have to get ahead of the restoration. You have to talk to the patient and tell them that, Mrs. Jones, your tooth doesn't have a lot of tooth structure. I'm going to do my best to restore it, but there's a good chance that that restoration is going to come off. And when you do, you call me. Now they're not angry at you. They're not pissed when the restoration comes off. You got there ahead of time. So let's talk about the cohesive luting versus bonding. And this is what I was talking about. When you have the 6 degrees of taper, 4 millimeters, look, zinc phosphate worked for years. I still have these older patients that got their crowns done in the 70s and the 80s. never came off, and now it's time to redo it, and you still see zinc phosphate underneath. Why? Because zinc phosphate wasn't the thing that was bonding. Zinc phosphate was a really good antimicrobial agent that kept it from leaking, but the restoration was sitting not due to bond, it was sitting due to the retention. It was a really good prep, right? So I'll remove the old cement, I'll particle abrade the tooth, and then whenever, if the prep is really good, anything works. In my practice, I'm using Unisem, I'm using Theracem. It's a same cement, it's a little bit less expensive than Unisem. It's got MDP in it, and you're not relying on the bond, you're just simply relying on the prep. And then you cure the restoration, clean the cement. You don't need a rubber dam. Majority of these restorations I'm doing with something like a Isovac or Isodry. I use a dry shield in my office. It's by a company called Cellmedics. That's my go-to. So here's a case where one tooth we could bond because we have plenty of enamel. We're restoring tooth number 12 and 13. 12 has a big MOD composite. The tooth is sensitive on pressure. It's reversible pulpitis. There's secondary decay. Tooth number 13, I told her, I was like, Maria, once I take this apart, I'm not sure if I'm able to put this back together. You're not going to grow old with this tooth. She didn't like the color of the tooth. There was a black, she had a really high smile line. There's a black line right in her smile line. So we wanted to redo the restoration. We know it's an unpredictable restoration. She's not ready for an implant on that side. We tried to restore it. I removed the restoration. You could see tooth number 13, way over prepped. There's not much tooth structure. It's pretty weak. We still attempted to restore it, but the patient understands that she's not going to grow old with that tooth. We bonded it on. We're using both retention and bond for number 13. Number 12 is strictly an adhesive restoration. And here's my adhesive restoration of number 12. Here's my cohesive / adhesive restoration of number 13. This was right after the cementation. The gum's a little beat up. That's going to heal. It did heal beautifully. She's going on 4 years now, but any day we know that this restoration could come off in her hand. And when it does, she's probably going to get an implant. So delivery of the restoration, these are your thought processes. When to use silane, when to use MDP, adhesion versus cohesion. So first we're going to start with the restoration. You received the restoration, you already prepped the tooth, you got the restoration from the lab. What do we do with the restoration itself? And this is more for my staff. This is my assistants. Whenever they get the restoration and they know it's Emax restoration, my ceramist etches the restoration, but they check. If they don't see that it's been etched, they will etch it in my office. They will etch it for 20 seconds with 9.5% hydrofluoric acid. And if it's a zirconia restoration, they're going to particle abrade it. We have lab unit, same exact pressure, 1 pound of pressure, 27 micron aluminum oxide, and they will particle abrade it. So if it's Emax, my assistants will hydrofluoric acid or your lab tech, and they will put silane on it. Here's another pearl. If you put silane on your Emax right away, it creates like almost like a glossy surface. So when you're trying the restoration, it doesn't get contaminated because the silane creates almost like a Teflon. And this is from Ed McLaren's work. He showed that you could, if you silane it and then you try it in the mouth, you don't need to re-clean it. All you do is you just clean it with water and you're done. Zirconia restorations, I'll particle abrade it. I'll try it in. I'll particle abrade it one more time to clean off any of the phospholipids. You could use a product like Zirclean. You can't over particle abrade zirconia. You could do it as many times as you want. Never particle abrade Emax. And then we apply MDP primer to it. I use Z prime, and then you follow the exact same steps, 3, 4, 5, 6, whether you're doing Emax or you're doing zirconia, and I'll take you through those steps. So these are the steps for your assistants: hydrofluoric acid, silane, or if it's zirconia, particle abrade, MDP. And here is 9.5% for 20 seconds. You could see this ECM slides. D is 9.5. You could see the more you etch it, the bigger the surface texture become, but you don't want it to become too big like E and D. The best is going to be B and C, where it's 9.5% hydrofluoric acid for 20 seconds. You can also use monobond. For me, porcelain etch, 20 seconds. If I don't see that it's been etched, just in case, I'll do it again. And here's the zirconia. This is from Dr. Lawson's work. When you're looking at an ECM of zirconia, when it comes back from the lab, it's very polished, right? That's the first slide. You can use glass beads, but glass beads don't create a texture. All they do is they clean. There's somewhat of a texture, but glass beads is for cleaning, and alumina is cleaning and creating this microporosity that the restoration could grab onto. I love a prep start. That's my chair side. We also have a lab unit that we use in the lab for when the restorations come back. You could use these micro etchers. I used to use this one, the one that you see there, but the tips, I would always lose the tips. I have no idea which one it is. We were always out. So I just switched to a prep start. It's one pressure. It's 27 micron aluminum oxide at 1 bar of pressure. We used to use these micro etchers, but they do create a big mess. Prep start to me is the best. So we decided that if it's a zirconia restoration, you could bond it, you can glue it using MDP. And if it's Emax, you can use it adhesively or you could use it cohesively. So we went through that. And silane is really important for Emax because silane creates a bond between the porcelain and the resin composite, right? This is from Young-So Rowe's work. You could see there's porcelain, silane, resin cement, bonding agent, tooth, typically enamel, right? Not just tooth, but enamel. I need to change that in my slide. And here, the silane, the alkoxy groups are activated by hydrolysis right in the middle, and those create a really strong bond between the porcelain and the resin cement. The challenge is that it needs to be activated. Now, some silanes come in a 1-bottle system that they were already activated. You just have to put the drop on. But the problem is that the activator sometimes can evaporate. So in my practice, we have a 2-bottle system. We combine it, we mix it, and I know that the activator hasn't evaporated, and I know that the silane itself is good to go. We have 2 bottles in the lab for my assistants, and we have a 2-bottle system chair side if I need to re-silane the prep. For me, 1-bottle system is really good if you go through a lot of it, if you know that it's not going to evaporate and your assistants are really good at closing the cap. But if it's not, just get the 2-bottle system and it'll last you longer. And this is a slide, know what's in your bottles, right? Z prime is going to be primarily MDP with some alcohol. There's MDP in the 3M, Scotch Bond Universal. There's going to be MDP and silane. There's going to be silane and methacrylate and monobond. For me, I like to separate. I don't like the all-in-one. Right, my bonding agent is All Bond Universal from Bisco. It has MTP and bonding agent, and that's it, right? And then if I need pure MDP for zirconia, that's just going to be my Z prime. And then if I need silane, I have silane for A and B. So I keep it kind of simple. There's 3 things. It's either bonding agent, Z prime, or silane. I don't have that many bottles in-house. So we try to keep it very simple. And MDP is this, it's this chemical called 10-methacryloyal dihydrogen phosphate, or MDP. Say that 10 times fast. What that does is it creates a bond between the phosphoric groups, which bonds to calcium, and the polymerization group, which bonds to your metals. It'll bond to your zirconia, it'll bond to metal. MDP is really good. So if you have someone that has like a PFM bridge and you want to bond some composite on there, you can particle abrade the metal, make it really rough, put your MDP on it, and then you could layer some composite. It's, you'll get, it's not a permanent bond, but I've had really good luck bonding composite to metal. It's not a sure for all. It's not super predictable, but MDP is found primarily in Z prime for your primer for zirconia. It's found in 3M universal cement, Scotch Bond. It's found in All Bond Universal, which is my go-to. And that's what basically Gluma is. Gluma desensitizer is pure MDP that you're putting in on dentin. For me, I don't use Gluma. I particle abrade my dentin, and the aluminum oxide plugs up the little microtubules, and it also increases retention. So I don't use Gluma. In my practice, I don't need any more bottles. It's either Z prime or All Bond Universal or silane. So zirconia gets particle abraded. We put the primer on, which is Z prime. Emax is going to get hydrofluoric acid etch for 20 seconds, 9.5%, and then the 2-bottle system of silane. So now you know which way to go, and now you have to decide, what cement do I use? Well, am I gluing it? Am I bonding? As I covered this was the slide. If it's a perfect prep, it doesn't matter what you use. You could use, water. You get sometimes these restorations, these implant restorations that are perfectly aligned and you can't remove it because of water, right? So for me, I'll use Unisem, Therasem, etc. Here is an example of cementation technique that I'm using for Emax. Patient comes in, second molar is hot and cold sensitive. Here's I already showed you the prep design. Restoration comes back. What we do is I used to use Ivoclar, Ivoclean. Now I use Zirclean. It's less expensive. It removes the phospholipids after trying, but if you silane beforehand, you could skip that step. You can do it if you want to, but it's an extra step that you could skip. And then we put silane. What I do is I put 2 coats on, and I have 2 syringes on my chair. One is air water and one is just air. There's no water in that line. So I'll very lightly dry or evaporate the silane. And I do the same thing to the bonding agent because I don't want to get any water or moisture either on the restoration or on the tooth. Here's whenever you're gluing or you're bonding the restoration, it's much harder, so you have to use a rubber dam. So for me, I'm particle abrading the tooth. I'm putting 2 coats of Bisco's All Bond Universal. I'm air thinning the first coat to evaporate some of the bonding agent, so it's not too thick, and also to evaporate the primer. And then what I'm doing is a second coat, and then I'm air thinning it again, and then we're light curing it. And whenever I'm etching, I don't have a picture of the edge here, it's always selective etch. You don't want to edge dentin. You already particle abraded it, you already cleaned it, it's done. Don't etch dentin. You're going to cause sensitivity and you're going to cause those tubules to open even more, decreasing the bond strength and bringing more MMPs into the area. So only selective etch. I'm only etching the enamel. Then after I'm bonding the restoration, My go-to is the same company by Bisco, is my dual link cement. I used to use the Reliax. I used to use Verilink. All of these work great. Verilink I will sometimes use if I need to lighten the restoration or darken it. It comes in light plus or warm plus, but my workhorse in my practice is my dual link. I'll sit the restoration and then I'll use glycerin. I'll tack cure it, and then I'll use glycerin to get rid of the air inhibiting layer, so I don't get those black lines after after I cement it. And here's the before and after. Here's the restoration on the left, here's the restoration on the right, and of course, to prevent this restoration from breaking, the patient is getting an occlusal equilibration, because to me, anytime that a second molar has a crack or break, something's going on with CR. That's for another lecture, but they're getting an occlusal equilibration, or they're responsible for my lithium disilicate breaking. I'm not warranting this work unless we figure out the why. And here's a zirconia, same exact steps, except for what I do to the crown, right? The crown, this is zirconia. Patient is a clencher. They broke that metal restoration. The distal is totally fractured. So the restoration gets removed. Zirconia restoration is made. When it comes into the office, my staff particle abrades it. I try it in. I adjust my occlusion. I adjust my contacts. I apply my Z prime to the rest. I clean it, and then I apply my Z prime. I selective etch enamel under a rubber dam, all bond universal sem. Now it's the same step as lithium disilicate. I particle abrade the tooth. Here you could see on the inside is my TheraBase to protect the pulp. I particle abrade the tooth, particle abrade the enamel, selective etch the enamel, 2 coats of all bond universal, and then dual link to cement the restoration, finish, polish, adjust. This restoration specifically is going on 4 years now, no issues. Purely adhesive, there's no retention here. And now we talked about the 4 millimeters of prep height. Imagine you have this giant MODBL amalgam. You remove the restoration. You don't have enough intaglio. This is where a core buildup comes in. And remember, the core is not to retain, when you're placing a post, if you're placing a post in the core is to retain the crown. The post is to retain the core and not the crown, right? So you can't use the post to retain the crown. That patient's going to come back with the post and the core and the crown all together. You need tooth structure. So if I don't have 4 millimeters of prep height, or at least 2 millimeters of tooth structure, the patient understands that this is a very risky restoration. So here, the restoration is removed. The amalgam restoration is drilled away. I particle abrade the tooth. I put my rubber dam on. In this specific situation, he couldn't handle a rubber dam. He's got this giant tongue. So I used a dry shield here. I don't like to do it, but I do it. TheraBase got placed to protect the pulp because it's very basic and releases calcium and phosphate. We cure it. Then I selective etch enamel only. I apply 2 layers of bonding agent, and I use my floor core by Bisco. That gets on, I cure it, and now I prep it exactly like a tooth. I do my depth cuts, I prep the tooth. I'm using a retention, 6 degrees of taper, 4 millimeters of of prep height, at least 2 millimeters of solid tooth structure, zirconia restoration. This is my temporary, same thing, it gets scanned. I used to mark my margins. Now my ceramist knows already where my margins go. I don't have to mark them. They know where I am. Here's my temporary restoration. Patient wears it for 2 weeks. I'm sorry, this is not Emax. This should have said zirconia. I need to change the slide. This is a zirconia restoration. Zirconia restoration is made. I particle abrade the inside. This is again zirconia. I clean it with Zirclean. I particle abrade it. Z prime goes on, and then I cement it under a rubber dam using dual link. Even though this was a cohesive restoration, I still wanted to bond it on. And even though I had really good retention, I still wanted to bond this restoration. So the choice is yours. You could bond cohesive restorations, or you could just sit them over the top. Here, I wanted a little bit more security because the patient broke the original restoration, so I didn't want the force of the bite to knock it off. And here's the before, here's the after. This is zirconia. Yeah, this is going, I believe, also 4 or 5 years at this point. So do we use a rubber dam? Whenever it's adhesive, I can't see doing a predictable restoration, adhesive restoration without a rubber dam. The studies on rubber dam and adhesion are wild, right? So you could use a dry shield, you could use cotton rolls, but if you're getting any moisture, even from their breath, that bond is going to be severely diminished. And I just don't see how you can't use a rubber dam. So yes, use a rubber dam whenever you can. I place it, I tie a knot, I get my margins, and now I am free to, the assistant could mix things. She could hand me my bonding agent. She's not retracting or packing, cotton rolls. I particle abrade the tooth. I selective etch the tooth. I bond it. Here's my restoration. This is a different one, but yeah, rubber dam whenever you can. This is a patient that you could see the tongue is completely flopping over. Yes, I could have prepped these completely for a full 360-degree crowns. I didn't want to do that. He's a severe clencher. He broke the existing composite. There was secondary decay on both restorations. I did a very conservative prep, Emax. Without a rubber dam, there's no way I could do moisture control. Yes, you could try to use these dry shield, or you could use, but for me, a rubber dam is a must. I'm cementing the restoration, particle abrade the tooth, selective etch the enamel, bond the restoration, Emax goes over the top, glycerin. This is probably 6 years at this point. I would say at least 6, maybe 7. This is pre-COVID, so way pre-COVID. So this is like 6 years at this point. So yeah, cohesive is going to be less conservative. Adhesive is going to be more conservative. Cohesive, if you're just going to be gluing it on, you could use a dry shield. I use dry shields. But if it's adhesive dentistry, rubber dam is a must. Here is a case where I'm going to take you through where it's both adhesive, cohesive, and a core buildup. Patient comes in, he completely broke the distal of tooth number 31. Tooth number 30 had severe decay and needed root canal therapy. He was in a lot of pain, irreversible pulpitis with a PAP on tooth number 30. 29 had secondary decay and needed to be restored as well. So I put on my rubber dam. I remove all the restorations. You could see that in the third slide. I place my matrices. I particle abrade everything, selective etch everything, and now I'm using my TheraBase and I'm using my floor core to rebuild the teeth. And you could see that on the lower third slide. I used Emax for all of these restorations. I removed the secondary decay on tooth number 29. There was a heavy decay on the distal margin. You could see that while I was prepping, it did tear the rubber dam a little bit. Then when the restorations come back, particle abrade the teeth, selective etch the teeth, 2 coats of All Bond Universal, dry everything, and then dual link cement Here's the restorations. Um, um, all Emax. This is about 3 years ago. No issues. Tooth number 30 was endo treated, and yet I still did kind of this conservative prep, trying to keep as much. What you're seeing is not a big prep, it's just the bevel where it blends in the color. So if I take you back to the prep, here is tooth number 30 and 31. You could see it's very, very conservative. The buckle it's like almost like a veneer lay sort of a thing, where I have enamel 360 degrees around on the mesial box. You can't see the rubber dam kind of went in the is blocking the enamel there, but I have 360 degrees of enamel. TheraBase is lined on all 3 restorations to protect the pulp. Well, except for 30, I don't need TheraBase there because the endo's already done. But there's TheraBase in 29 and 31. Could I have done this in zirconia? Sure, but I wanted really good marginal seal. So for me, pressed Emax is where I'm getting my marginal seal, right? Patient got a deprogrammer. They got a Cois depro. This is not an occlusion lecture, but patient got a Cois deprogrammer. And when he came, when I gave him the temps, he got a Cois deprogrammer. And then when we put in the final restorations, his whole bite got recalibrated to take the pressure off of the second molars. Because if he's breaking the second molar at the distal margin, that has to give you a red flag that there's some kind of an occlusal discrepancy or occlusal disease. So to repeat, if you're going to go adhesive and conservative, zirconia works. And I know that there's some debate whether you can bond zirconia or not. I recently did a lecture for Viva Learning on bonding zirconia, so you could take a look at that. A lot of this kind of stuff repeats itself, but again, adhesive, Emax, or zirconia, the only different steps, if it's going to be adhesive, is what you do to the crown. The steps to the tooth are going to be exactly the same. Particle abrade the tooth, selective etch enamel, 2 coats of Volbon Universal, dual link cement, cure under a rubber dam. If it's at the top, zirconia gets particle abraded and MDP, lithium disilicate, hydrofluoric acid, silane. The rest is exactly the same. Now, whether you choose to focus on a margin seal, that's going to be more Emax. And if you're going to be strength, that's going to be zirconia. I hope that that kind of cleared everything. So without further ado, I'm going to go to the questions. Oh, yes. So that's a really good question. I'm not sure if I misunderstood. You use Reliax Unisem cement as a base. Yeah, I do. A lot of the times I do. Unisem cement is it's self-adhering to dentin, and it's really good, and it flexes. So you could use this as a base. You particle abrade the dentin floor, and then you're using the cement. It has great flexing properties. Nowadays, I'm 50-50 between Unisem and TheraBase. If I'm really deep to the pulp, I'm going to be using TheraBase. If I need to like block out the undercuts and I need to get into the, it's really easy to just particle abrade. My assistant gives me Unisem and I squirt it into those little nooks and crannies and on the pulpal floor, because it micromechanically locks into the dentin pretty well. It's not going to be a long-lasting bond because I don't trust bonding to dentin, but it's going to be, but it's a really good liner. But for me, it's either going to be TheraBase or Unisem. Have you ever had your zirconia crowns fabricated in China? No, not that I know of. My ceramist is here in Long Island, but where they get their zirconia from could be. The zirconia pucks could be coming from China, from India. Not that there's anything wrong with it. You just need to know where they're coming from, what's in them, how are they fabricating them, etc. No, I've never done gem. My ceramist is right here in New York. How are you cleaning your zirconias after trying? Yeah, so I'll try them in and I'll reparticle abrade them. I'll re-clean them using Zirclean, and that's it. So it doesn't matter whether you particle abrade a Zirclean or Zirclean a particle abrade. You're particle abrading to create a texture, and you're using Zirclean to get rid of the phospholipids. So to me, I don't think that it matters which one you do first, but after I try it in, I'll particle abrade it, and then I'll use Zirclean or Zirclean and particle abrade. Doesn't matter. And now what is the 30-degree matrix system you use? It's from Ultradent. Just type in matrix system from Ultradent. What are your thoughts on in-office milling to bond adhesive dentistry? What are your so in-office bond adhesive dentistry? So I don't do it. I don't have room for it, and I don't have the flow. Who's going to design the crowns? Who's going to prep them? Who's gonna so I don't do it, and I also don't think that the mill is very accurate in my hands. I know that there's a lot of dentists that do it and then they do a wonderful job, and that's fine. For me, it's much easier to make a temp and bring the patient back and renumb them and put in a Presti mix restoration. I think that's it.